For calling in. You've dialed into the Perinatal-Neonatal Quality Improvement Network project to improve our care of women with substance use disorder and opiate use disorder during pregnancy. We're looking to improve the health of moms, babies, and families here in the Commonwealth. And this is actually wave 2 of our 12 episode webinars, which is exciting. We finished the last wave about 2 months ago. COVID put us down a little bit, so it's really exciting that they're working through this, both with the OUD special interest presentations as well as the QI training. So we've got a great day planned for you here. Next slide, please. Great. So today we're going to just do introductions. So we do our introductions generally through the Zoom group chat. So please put your name and site on there, and you can see who's on with us. Always feel free to reach out to each other over time, because you guys are showing up for this. You must be working on this out there. So people are learning and innovating in their spaces. And at least for us, I know we're always happy to share at Boston Medical Center with anybody who has questions or comments or wants to collaborate on something. We're going to talk about updates from teams. We got actually some good feedback from some folks, so we'll bring that up on a couple slides. We're going to do some QI teaching. So we have Wendy Timpson here talking about run charts, core to good implementation of something. And then finally, Letitia Goulot, who's actually a peer recovery coach at Lynn Health Center, is going to come and speak with us for about half an hour about her patient experience, her lived experience as a person recovering from substance use disorder and having a baby. So she actually spoke, if you recognize the name, at our summit, and she was just amazing. So we asked her to come and speak to us today. Next slide, please. So webinar housekeeping. This slide is fun. It feels antiquated, reminding people to mute yourselves and how to use all the features is kind of cute. But next slide, please. Awesome. So these are the teams who are involved from wave 2. So you can see who's up here. We're really glad you're here. Most people are calling into most of these webinars, so we're glad you're here today. And they're also, don't forget, being recorded and put up on our website. So you're always welcome to look at them there too. Next, please. We have a larger team of folks who work in the Perinatal Opioid Project. This is our leadership team. We have our general crew from Pinquin. We have neonatal team members, maternal-oriented folks, academic organizations. We have lots of state partners, especially in this space. It's important to have all of our resources coming to the table. And then we actually have had some really wonderful families involved. And actually, we should put Letitia's name on that list of families. Next, please. Great. So in terms of announcements, move my chat box. We do have recordings from the OUD Summit. We had 2 excellent 3-hour afternoon summit days on the 17th and 18th of November. Feel free to look at those at your leisure. There's some really great inspirational presentations by lots of folks, including Ayanna Pressley, Congresswoman Ayanna Pressley. Great. Oh, great. Hi, Letitia. I see that you've just signed on. Thank you. We have online stigma, bias, and trauma-informed care trainings coming very soon. That's from the care team. I don't know if any of you all have had the people from the care team do a Zoom conference with you. People are finding them so valuable that we actually recorded one, and we really feel like a facilitated conference around stigma, bias, and TIC in relation to substance use disorder is really very valuable for a team. So that'll be available to you, in fact, with nursing credits available. We also are going to be sending out information for you guys at your hospitals. You exactly might not be the person to receive it, but just so you know, we're working on memorandums of understanding so that we can start to collect some of this, some data on systems, process, and structure measures. That'll start in, I'm going to guess, February or March with our teams at the Betsy Lehman Center. More to come on that. Just recognize that we are reaching out to your quality leads about more data. Thank you. Next. So we do have another important project that we're working on. We're working on, this is actually more specifically around the equity data roadmap. This was presented on day 2 of our summit, and there's a really good presentation by Susan Manning, and I'm forgetting the name of the other person now that I'm on the spot, but it's on the website to explain the equity data roadmap. And it's a really thoughtful way to approach our problems, really from the beginning, as we start to evaluate with data and everything, how our systems are set up and how we can have equity focused improvement. Next, please. There are more trainings coming up through the American Society of Addiction Medicine and ACOG on buprenorphine waiver trainings. All these slides are available to you online, so you don't. Antonia Blinn, thank you so much, Kaylee. So these slides will all be online for you guys to get if you want to sign up for this. We also have an MAT waiver training for advanced practice registered nurses, and good news is that's free. Next, please. We also have a continued relationship with the folks at MassBIRT, who really have done a great job. Wave 1 teams were raving about them. I'm not sure who's reached out from this group yet, but Alex Hines and her team really have a great way of thinking about understanding how universal screening fits into a clinic, how to set yourselves up for a successful implementation. So it's not just about brief intervention, but really thinking about how we set up for linkage and all the work that has to happen around screening. Very available to all of you. Next, please. This is what I was going to mention before. We have Speak Up Champions training, and this is training focused particularly on nurses, but all providers who've been exposed to these trainings have been really enthused and very positive towards the education on ways to eliminate racism in the way we take care of patients in the hospital and outpatient. And this is being funded through PinQuin as well as DPH. So again, free. Please register. Next. Thanks. It's fun to actually do some team updates, some check-ins. Kaylee put out a scanning email and she got a couple ideas back. So Beverly, if you want to sign on or come off of mute and talk, that'd be awesome. So they created and sent out a survey asking about provider attitudes towards breastfeeding and psychiatric medication. They sent out another survey. They sent that survey to RNs, OB providers, neonatologists, and pediatricians. If you guys have any answers from that survey, that'd be great. Their question for everybody, and feel free to chime in with either chats or come off of mute. We're still trying to figure out a way to implement the 5 Ps. It appears to be more an outpatient tool. True. Our challenge is that we have a substance use screening tool already built into Epic that we cannot manipulate. We're wondering what other organizations with Epic are doing to meet this recommendation. I have an answer to that, but I'm interested to see if anybody else has had any answers or luck in that space. Anybody from Beverly want to elucidate anything around this. So I'll say, I will reach out back to our Beverly team. We actually did take the 5Ps and we ended up putting it on the other side of the EPDS. Oh, Teresa, I'm sorry. You're on, but we can't hear you. Maybe Kaylee has you muted. If not, I'll keep talking. Feel free to interrupt.
Look like she's muted. I don't think it's on our end.
Okay. This happened the other day when I was on with somebody. Okay, so we do have 5Ps on our on Epic. I'm glad to share any screenshots with you if you're interested. And in fact, when we had it as a written form, we had in the other side of the EPDS or Edinburgh depression screen, and we can share that with you as well. Let's see, Teresa, I will definitely get back to you on that. So on my to-do list. And I'll share that with anybody else who wants it too. Let's see. Great. We're still obtaining responses, very thorough inquiries regarding the use of medications. Great. All right. Next slide, please. And then from South Coast, great. Yes, I will share with you at South Coast. Okay, more to come. All right, I can actually, maybe I'll just share it out to the whole Wave 2 crew. Over the last month, we've worked on evaluating universal screening tools for use in the office and triage. Awesome. And what universal tools are you using? Are you using Epic as your EMR, and what barriers to implementing it? Anybody want to chat in what they're using? I do know that a lot of people who are in the partners system are using the NIDA Quick Screen because that was what the hospital was using. And they have it in Epic is my understanding also. We're using 5Ps. Just a heads up too, if you're interested in the 5Ps, also the Illinois Perinatal Quality Collaborative, so it's ILPQC. If you hit Google under 5Ps, that seemed to come up early on for me when I was looking at this. And they have a nice description of 5Ps and why they were recommending it. So that's there for you guys to look at also. And I'll send you, some stuff from BMC as well. Anybody else? Anybody using anything else besides NIDA, Quick Screen, or 5Ps? Great. Oh, good. That's great, Agnes. Yeah, Alex is great. She really gets this process. She's done this a lot. Okay, well, I'm going to move on. Next slide, please. And ta-da, we're now at our QI webinars, topics for QI teaching. And so you can see the list of things. We try to sort of follow what the usual process is for a quality improvement project. And we're now to run charts. So I want to thank Wendy Timpson, who actually hails from the Beth Israel Deaconess Medical Center. I've seen this presentation, it's excellent. And she's just gonna go over run charts, which is just a really wonderful way to keep track of what we're doing and monitor our progress as we do implementation. So I'll turn it over to you, Wendy, thank you.
Great. Thanks so much, Ron. I'm excited to be here today to talk about this topic. I love QI methodology and teaching QI techniques. Could talk about it till I'm blue in the face, but I'll try to not talk about it until you all are blue in the face. So this will be quick. And it's really a very brief overview. I know through the collaborative, you have lots of access to these resources. So this is just meant to be kind of an exposure for you all if you haven't started using run charts or heard about what they are. and hopefully lots of opportunities for you all to dive into this topic more deeply as it's useful to you. Next slide. So today's goals in our brief time together is to show you the benefits of looking at your data over time as you implement new processes in your QI project. Expose you a little bit to the concept of identifying variation in your data, which can help us highlight potential opportunities for change. Really quickly show you how to make run charts. This takes 2 seconds because they're actually quite easy to make. And then expose you a little bit to the idea about looking at your data and telling you what opportunities there are in your project or that your data reveals about what you can change in your system or your processes. Next slide. So measuring over time matters. Many of you have probably been exposed to kind of this pre and post data. It's often what we use in research when there's one intervention that occurs between the 2 periods of time. So this is an example of just that. You all have been working on implementing universal screening measures in your population, which is terrific. And if you take a look at this data and you think, well, we were at 50% when we started, and we, in our post-intervention, our post-QI project, or our post-PDSA cycle, we reached 90%, you might look at this data and think, well, this is terrific. It's been a wonderful, phenomenal success. And it very well may have been, but this is a bit of an simplification of the data, and actually can be misleading if you don't kind of sparse it out over time. Next slide. Next slide, Kaylee, thank you. So this is one potential. This is the same exact average data. Instead of looking at it into 2 subgroups before and after the implementation, we've actually plotted it here over time. So this is looking at the percent of patients who received universal screening over time, grouping it by month. And if you happen to know that you performed some big important intervention, a PDSA cycle, right around January, you would probably look at this data and say, well, perfect. We made a clear improvement here. We were kind of hovering around 50%, and now we're up around 90%, and it looks like we're staying there. Next slide. There are other possibilities, though, within your data. So one possibility is actually just that the things have been improving over time even before your intervention. Screening was going up for other reasons, and it's hard to tell by this data what that might have been, but you can see here that it actually doesn't look like your implementation of a new process was necessarily associated with a real change in the data. The data was already improving before you intervened on your system. So that would be important to know, because if your intervention takes a lot of effort, time, manpower, it's not necessarily a wise idea to kind of continue working on that. Next slide. Another possibility, which is even more concerning, is actually that things were going along okay. You implemented a change, and initially you had a great response. However, over time, it seems to be that your screening rates are going down after implementing that change. So a couple of things. It could have been that big increase after your process change just really had nothing to do with that process. It was some other random effect that was going on in your system. Or it could be that it just didn't have a lasting effect. So you would, knowing this, you would want to go back and actually look at that change to see if there's anything you can do to make it more cooked into your system or more permanent. Next slide. So same data, 3 different stories. And this to me really speaks to why it's a good idea to be plotting your data over time and looking at how your interventions are impacting your system, or looking for other signal in your system, because you're going to want to react differently in your QI work. Next slide. So variation tells us about our system. Variation in our data can tell us about what processes are working, what processes are stable and staying the same over time, and what processes are unstable. I felt okay about including this picture because that's actually me in the corner of the greenhouse falling over trying to do yoga during a pandemic outside. Next slide. So we think of a product line in a factory as being a very stable process, right? Highly regulated, lots of checks and balances. You get the same product every time. You could have a very stable system like this Google image that I stole, which is a factory in Japan making cars, or you could have an unstable system where you've got something intervening on your system and you're going to have a different product at the end of each of these cupcakes or whatever it is that Lucille Ball was trying to produce come off the production line. So it's important to know if your system is stable or unstable. Are you creating the same product every time, or are there influences in your system that are making you have a different result every time? Go ahead, next slide. So looking at data, you might look at your opiate use disorder screening and think about whether it's stable or unstable. This is an example of a pretty unstable system. Some months, like in June of 2020, you were screening 70% of mothers. And then in April, you were down to, looks like about 10%. So this is a lot of variation or an unstable system. One of the interventions you might want to make, if this is what your data looks like, is actually just trying to reduce that variation. Just try to perform more consistently so you can have a more consistent product, which in this case is consistent screening of your moms. Next slide. So it's important to also look at your data as you think about these interventions and think about, am I making it more stable? And I think you can appreciate over this graph over time that you can actually see that an unstable system, which is actually our data that was just on the last slide, you intervene. And while you actually haven't changed the median, which is 40% of women getting screened here, you have definitely achieved a system that has more consistency. You are more likely to know what's going to happen next in your data. So if you don't make another change, you would expect that in November, you're going to roughly have about 40% of women receiving their screening. Next slide. Okay, so stable and unstable. Another thing that's important about variation is whether the variation is random or non-random. So again, stolen right off of Google. Random variation, the top picture, you don't know which pup is going to come out a different color from the lab litter, right? It's a little bit random. Actually, there may be some genetics that I don't fully appreciate that drive this, but essentially random. We also refer to this type of variation as common cause. People think about it as natural patterns, things that are usual or typical, sometimes consistent with historical data over time. Another type of variation, which is super important to understand and appreciate as we plot data over time, is non-random. And we refer to this in QI as special cause. So something that is unusual that is happening to your system that hasn't previously been observed. Next slide. So here's an example. This is my daily commute. These are actual fairly accurate estimates of my daily commute last spring in March. I live out in Concord, so sometimes I hit traffic and it takes me 80 minutes to get in. Sometimes I can get in quickly. You almost notice here that it looks like there's a little bit of a pattern to it. So on the 14th and the 15th, it was quicker for me to get into town. It actually turns out that those dates are weekend dates, as are the 21st and the 22nd. So here's some common cause variation. This is just typically what I experience in my commute. Sometimes there's changes in traffic patterns, the day of the week changes. This is common cause variation. It's just kind of the normal natural variation of the system. Next slide. So we call that normal variation noise, natural variation of noise. And then when we see something that appears to be different in the data, we call it special cause or a signal. So if anyone remembers what was happening back in March around the 24th, that was just about when things started to hit the fan in Massachusetts with the pandemic. All of a sudden, no one was driving into the hospital, or I should say no one was driving into Boston. A lot of people were driving into the hospital still. So there was something special about the system that changed, that was different. It was unusual. And we notice in our data here that there's actually a signal. Something different is happening with the data. For the first time in many days, it only took me 20 minutes to get to the hospital. And then another thing we see with this data is actually that it stayed pretty consistent over time. Luckily, that's one silver lining that still persists. Next slide. So why does it matter? The type of variation can help drive changes that you might want to make. You might want to test and try in your system. If there's a lot of special cause data, so things that are influencing your system that are not a typical pattern, they're not natural, you are going to want to try to reduce that variation. If there's common cause variation, you want to try to reduce that. So it's really going to try to change overall the the different tests that you implement in your system to try to establish a more predictable pattern for your patients. Next slide. All right, so kind of jumping the gun here on all that because I haven't really told you what run charts are in the first place. So run charts are very simply plotting your data over time. You can, so on the x-axis, you have time. It can be grouped into months, weeks. You can plot individual patients, which actually can be really helpful as you're starting off a project, is to just plot one patient at a time. On the y-axis, you have whatever the measure is. So if it's % of women receiving the screening, et cetera. Every time you make an intervention on your system or you test a PDSA, implement a PDSA or test one, it's a good idea to annotate it, write it up on this run chart, mark those, because over time, you're going to notice patterns. You're going to notice whether or not your intervention has changed your data, has changed your system. For run charts, we use a median, and you can plot that median over time as well. That's going to help give you an estimate about where you are overall. Another really important tool that Ron suggested I mention is auditing. So you don't necessarily have to measure every single patient if that's not convenient. You can audit a certain number of charts. The important things about auditing are that you have to have a pretty frequent or pretty common occurrence that you're measuring. So you don't want to be doing audits for something that occurs very, very rarely, or you might miss them or miss those occurrences. But as long as whatever the thing that you're measuring happens 20 to 30% of the time or more, you can pretty successfully choose a handful of charts to audit. The other really important thing is that you do it randomly. So you don't want to just pick the first few charts of the month, because there might actually be something different that always happens the first few, kind of days in the month and that kind of thing. You want to do it really as randomly as you can. Next slide. Okay, so here's my pep talk for run charts. Plot data as soon as you have it. So one or two points, as soon as you have them, put them on a run chart. And you can literally take a piece of graph paper. I think I have a picture of it later. And you can just mark them on a piece of graph paper. You don't need to use fancy software. You don't need to make them look nice, but they can tell you a lot about your system and the changes you're implementing. I mentioned using random sampling. And when you have 10 data points, you can actually start to calculate the median line and adjust it. So that means that if you see signal, which we'll talk about in a little bit, statistically significant change, you can actually start to think about, oh, has that actually affected my data overall in a way that I can start to shift my median, or looking at the kind of the typical behavior of my system. And then after that, we'll use these probability-based rules, which I'm going to tell you about super quickly. Next slide. Okay, so I'm not going to go into this into great detail, but this is basically just to show you there are patterns that you can see in your data that are statistically significant. And they actually statistically tell you, just like we do in traditional research with a before and after study and measuring p-values, that your system has changed. On the top left, we have something called a shift, which is when you have more 6 points or more above or below the median. If your data has kind of shifted in this way, that's consistent with something different happening in your system. This top right shows you something we refer to as an astronomical data point. So there's something special about that. I think everybody can look and see without statistics that there's something unusual going on there, something that's not a common cause variation, something that's special. We don't know what it is, and without annotating our run chart with our PDSAs, we don't know if it was us or something else that changed, but these are important things to know about. So there's a couple more examples in the bottom about special cause that you can use these probability-based rules to actually identify statistically significant change in your data. And I'm sure there's lots more. Ron can probably point you towards more resources through PinQuin as to, like, if you actually want to start looking at these rules, how to know when to use them and that kind of thing. Next slide. Okay, so what do we do when we see a signal, one of these special causes or a probability-based rule? It really is an opportunity to learn about your system. So if you're plotting your data over time and you notice something different, number one, just stop and think. Did something change in my system? Was there something that I wasn't even thinking about that's new or different? And then the other thing is compare it to interventions, like I've been saying. Compare it to those PDSA cycles and see if potentially your project, your work had an impact on your system. So it could be evidence that something's gotten better or worse, and both are important for you to know. Next slide. So here's the graph I mentioned. This is one I actually found online too. If all of our weights did this over time, I think we'd all be using run charts, right? Like if that was my daily weight on the scale, I'd have a run chart up on my wall in my bathroom. Really important for QI. So really in quality improvement, we consider this the minimum standard. You don't want to be making changes on a system if you're not measuring them and understanding what the impact is. They're really simple to make. Start with a few data points. After you get to 10, start to think about those rules, those probability-based rules to identify statistically significant change. I've mentioned annotating them, and really do use them in real time. You can put these up and show them to your QI team, show them to your leaders at your hospitals, and it's a great way to kind of share your successes. I think that was my last slide. Yep.
Wow. Wendy, thank you so much.
You're welcome. I talked fast, sorry.
No, it's super understandable, and that you know, if you watch that and didn't get convinced that you know, run charts are not so hard to do and potentially impactful, that would be surprising. So, does anybody have a question for Wendy? And I will say that, you know, again, these slides are available. You can take a look at them. And these are very good references. There's a lot of this stuff in here if you want to read more and understand. But it really is the best way to understand if when we do something, we actually are getting the change that we want. So I guess without further ado, we'll move on to our next phase here. So thank you so much, Wendy. That was great. Okay, our next speaker is Letitia Goulot. She is a peer recovery coach and you know, a friend of Penguin. And I just want to say thank you so much, Letitia, for coming to talk to us today. We try to keep it sort of open to what is important for patient voice participants to bring to our conversation. And so I'm really interested to hear what, your presentation today, Letitia, and I hope that that you're doing well, and we're really glad to have you. So thank you so much. I'll stop.
Thank you, Ron. Yeah, I was going to say, Kaylee, you can take the slide down. So my name is Letitia Goulot, and I am the peer recovery coach / peer mom on our Moms Do Care grant that operates out of Lynn Community Health Center. We're funded by DPH, BSAS, and I wrote it down, and SAMHSA. Laura Sternberger would be mad if I didn't mention that. And I think most importantly, though, I am a mother in recovery from, I guess I would say on my chart, like an opiate use disorder. I really don't discriminate between substances, though. When I tell my story, like, you could have handed me a cup of urine and told me it was going to get me high or take me out of myself, and I would have taken it. And you know, I have 3 little ones. I have a daughter who's 5, and I have twin boys that are 1.5, almost 2. And yeah, so how I usually like to run any sort of training or any sort of talk I'm doing is just give you a little background about me and how I came to be where I am today. I think a lot of times, you know, in working with moms who are either struggling to enter into recovery or in recovery, or currently using, it's hard to see past the chaos of that is addiction. You know, it's hard to see past the chaos of someone who is working in sex work or, you know, living in a tent and they're pregnant and you're worried about them. And that can sometimes be all you see. And so what I hope to accomplish by sharing my story over and over and over again is, you know, you see in front of you a very well put together, responsible, accountable mom, friend, sister, patient, very pleasant to be around, that that is not who I was 5 years ago. And, you know, I just hope to give a different face to what we see as a substance use disorder. So yeah, about 5 years ago, yeah, a little bit, 5 years ago in a month, I was very actively using, and I was pregnant with my daughter. And I got my care here at Lynn Community Health Center, sporadic care. But, I would come into the OB office and I was a mess. I would, be in withdrawal in their waiting room and just really unpleasant to be around. And I was met with such like amazing compassion. Nobody ever told me to like, get out. I had to reschedule. I was being disruptive to other patients, which I was, all valid like statements. And, they really just met me with kindness every time I went for a visit, which kept me coming back, even though I was deeply ashamed of that. Like I couldn't stop using. And I knew all the dangers of like using, I was using opiate stimulants, everything. I was using everything when I was pregnant. And I knew all the dangers. Like I didn't shoot heroin thinking it was going to make my daughter like really smart, or it was going to, make her the healthiest baby. But I just couldn't stop as much as I wanted to. I tried over and over again to self detox, and it really just wasn't working. And I ended up going into treatment when I was about 7 months pregnant. And I did end up entering into recovery and sustaining some recovery throughout, or I'll call it abstinence. I really wasn't working any sort of program of recovery, but I was able to remain abstinent throughout the rest of my pregnancy and deliver a baby, that didn't have any substances in her system, and I didn't have any substances in my system. And I thought that I was going to take that baby home from the hospital with me, and that was not the case, due to like my lack of prenatal care and some positive urine drug screens throughout my pregnancy. There was a 51A filed when I delivered her. And I tell this story not for like the shock and awe value of the story, but to really try to give voice to the trauma that our patients go through. So I had a C-section. I think we were on like day 3 because I was due to be discharged the next day. And a nurse came in and told me she was going to take my daughter to the nursery to get some shots. And she took her out of my room, and 2 minutes later, my phone rang, and it was a phone call from DCF telling me they had just taken custody of my daughter. And I was devastated. I had felt like somebody had reached into my chest and ripped my heart out. It's almost like a instinctual, like animalistic response I had at that moment. So that poor nurse that, probably was just doing her job, following hospital protocol, telling, in my eyes, though, she was just lying to me. So when she came back in to apologize for lying to me and, check on me, I was not happy with her at all. And I was very inappropriate in my behavior towards her. And she left. And then the nurse manager came in of the OB floor of the labor and delivery unit. She came in and she, I thought I was in trouble. I was like, oh my God, they're going to kick me out before I'm even ready to be discharged. And no, she sat down next to me on my bed, and she held my hands, and she told me she understood like why I reacted the way I did, and she couldn't imagine like having her children ripped away from her, and that, it didn't reflect on who I was as a person, and that I could do this, and that I could, get custody of my daughter back, and she would be there for me. And that kindness, like I really think, there are a lot of little moments along my journey where I was met with like compassion and kindness that I really think propelled me on into the journey I am today. I've been in recovery for a little over 5 years now, and I did regain custody of that daughter back, and I went on to have 2 more children, and all while trying, like, not to be graphic, but like trying not to stick a needle in my arm, because like at the end of the day, like that's what I have to do. I have to like show up for life and try not to stick a needle in my arm on a daily basis. And there were little moments where I was met with kindness and compassion and understanding, and that was one of them. So fast forward, I went through treatment, and that's how I regained custody of my daughter. And I left that treatment program after being there for a year, and I moved into sober living with her, and I met a man, and I entered into like my first healthy relationship, and we ended up pregnant, and unbeknownst to me, it was twins, and I was very shocked, and I thought, how am I going to handle this? But I had built this network around me of like support through I work a 12-step program, and that's my recovery journey, and I had built this amazing recovery network that carried me through that pregnancy and like this newborn stage of twin boys, and also having a toddler running around, and that was really, really important for me. And I went to my 6-week follow-up at my OB, and they here at Lynn Community Health Center, and my OB was like, "You're doing this really cool thing across the street on the Sunflower team called Moms Do Care. And they're looking for a peer mom, and I think you'd be perfect. Do you want to like interview?" And I was like, I literally just had twins. Like, I don't know who you think I am, if you think I'm Superwoman or what, but you know, uh, I believe in God, and I believe that, everything happens for a reason. And for me, that was really a God moment. And I felt like God had put this opportunity in front of me. And how could I not give back like to the women who, I was, 4 years prior or so. And I just felt like I had built such a strong, stable recovery, and I needed to be able to show other women that that was possible. So I went to the interview, and I got the job, and I've been here, a little over a year and a half. And I'll tell you, it's the hardest work I've ever done. I mean, I've only ever slung bacon and like sold prom dresses, but this is definitely like the hardest work I've ever done. And but it's also the most rewarding. Like when I see, some of the most painful moments in my job are like sitting through a woman who just lost custody of her child, or, sitting with a woman who's pregnant and just feels like there's no way out and she can't stop using. But then I have these like amazing moments where I get to like see a reunification of a mom and a baby, or a mom and older children who she thought she would never get a chance to reconnect with, and the strength that these women have. I mean, I can speak from experience, the battle that it is to be a mom in recovery. It is a daily like climb of Mount Everest just to like remain in recovery and also show up for life. And, I hope that by sharing my story, you'll get a little glimpse into the strength that your patients have. I mean, I think it's really hard to see past the chaos, but I hope by sharing my story, I can show you that like these are also warriors that you're meeting on a daily basis. So that's my story. I like to leave time for questions because I'm an open book. No question is too provocative or too personal. I am an open book. So feel free to ask away. Both personal questions or related to the work. It doesn't matter.
Sorry. First, just thank you so much. So powerful. The two things I heard were the importance of continual kindness, and how, people do it once, twice, but just that continued and seeming so that it hits at the time that's most useful for you. I heard that, and then I heard strength. So really powerful, really helpful. I guess sometimes people you'll get these stereotypes of, decisions made badly or this or that. What do you say when you hear someone say, that sort of idea comes up in a conversation about a woman with this struggle?
I think that really comes from this inherent misunderstanding of what a substance use disorder is. I think a lot of people see it as a choice. And I think there's stigma with addiction, right? There's stigma with substance use disorders, but I think we add a whole nother level of stigma when there's a fetus or a baby involved, and people think that women should just be able to stop because they're pregnant. And I think people forget that this is a compulsive disease that, I had sat there. I was living in a hallway at the time, 6 months pregnant, and I was in tears, like shooting heroin into my veins, like because I did not want to be doing it. But I didn't see another way out. I didn't, I knew people in recovery, but I kind of thought they were like full of it. And I thought like, there's no way people are just like showing up to life like happy and like dealing with, I have a lot of childhood trauma and pain that I felt like I couldn't deal with. And so I think, I think that's where that comes from. And so that's what I would have to say to that. I said there was another question in the chat.
Thanks.
Um,
Do you want to read the chat questions, Letitia? Would that be easiest for you, or I can read them
yeah,
out?
no, that's perfect. I have the chat up. So Linda said, how long did it take for me to be reunited with my daughter? So I went into DCF had told me that the only way I was going to regain custody of my daughter was if I was in a residential program. So I entered a residential program here. Well, first I entered a residential program for all the wrong reasons, solely to get my daughter back. I ended up relapsing at that program. And then I ended up at another residential program that allows you to have a child there as long as they're under a year old. So I was reunited when my daughter was about 6 months old. The first reunification plan, when I first entered residential treatment, was going to be a 30-day reunification plan. It was written in stone. It was promised to me that I'd be reunited within 30 days. And I ended up having a recurrence and that ended up having the reunification take longer.
Well, thank you for sharing that with us. And also thank you for sharing about the nurse that was compassionate to you. Because I've been in that place where I've had to go in and take a baby away with social service, although that's not the way we do it. we explain it to the parent, but it's a heart-wrenching experience, not only for the mother, but for the nursing staff that are involved. So thank you for sharing that, and God bless you.
So there was another question from Agnes. It said, any message to staff working in the clinic that delivers prenatal care to a woman who's using front desk staff? Yeah, so I mean, that was my experience here at Lynn Community Health Center was, I was an awful patient. When I'm telling you I was an awful patient, like I was like throwing up in their waiting room, like screaming, like I need to be seen right now, like totally a patient you would want to just kick out of your waiting room, right? And everyone from the front desk to the medical assistants to the provider just was like, you're going to be okay. You'll be okay. Just breathe, like bring me nausea bags and like, just kindness all around. And so I think that's where like trauma-informed care training comes at, like, you need to do that training with all staff because, these women are going to, if I had been met with, non-compassion at the front desk, if I had been kicked out of that waiting room, I'm not sure that I would have gone back for any prenatal care at all. And I think that's the scariest situation we get into. My role on the grant, I think, is to like provide that safe space for somebody to keep them engaged, even if they're really not willing to engage in any sort of prenatal care. It's just to like gain some sort of trust so that a woman does feel like she has a place to come to if she's feeling like she needs something medically. And then there was another question comment from Ellen. Appreciate that you shared a positive defining moment. Please share some negative ones. What mistakes do we as nursing teams commonly make? Yeah, I think, one of the negative experiences I had, like, and this was sort of with providers more often, is it sort of felt like, and I understand that like as a medical provider, you need to like have these conversations for your own peace of mind, like knowing that, you had these conversations with patients, but it sort of felt like every single visit I was told like how bad drugs were for my baby. And I was just sort of like, it just added to my shame. And it just made me feel like, okay, I get it. I know this is bad, but I can't stop. So could you give me some options to stop? And I think, that's something. And then also, some things I've seen happen with the women I work with today is that staff can really end up taking the trauma responses that our patients are having personally, right? So like I've had a patient who was like cursing out one of our nurses on the phone. I don't know if she was like trying to make an appointment or what happened. And the nurse like hung up on the patient and the patient didn't come back to us. And like the context of that story is like she had just had a baby removed. And one of the things that DCF had said was, you know, some urine drug screens that had come from our clinic. So of course she blamed us. And I think just understanding that there is so much more to unpack in your patients besides what you see presenting in front of you. Yeah. And then there's one more from Wendy. Said, I don't think that wanting to be reunified with your daughter was necessarily the wrong reason, maybe just not the right time. Yeah, I think, you know, I think though, I hadn't done any of the inner work on myself for me, right? So when I went into treatment, I think the first time I went into treatment, I did it because I thought that's what I was supposed to do, right? I really, I think deep down now reflecting on where I was, I don't know if I even wanted to be a mom. I didn't know if I was ready. I didn't know if I had such low self-esteem. I thought like she deserved so much better than me. And so I sort of went into that treatment program because that's what DCF told me to do. And I thought like I'd be a bad mother if I said I wasn't ready for treatment at this moment. So yeah, I think like not the right time. I don't think I was completely ready to like fully give myself to recovery. And, you know, I think that's another big thing I see with the women I work with and that I experience. There's so much ambivalence. And like we talk about the stages of change all the time. And our women stay in that pre-contemplative stage for like a long time, right? Because like you know, when you're still using drugs, it's a quick fix. It's a quick way to not feel how you're feeling. It's a quick way to deal with trauma and it quickly numbs things, right? And so like when you see recovery, you're sort of like, what's the benefit to this? Like I'm gonna have to feel all these feelings and I'm gonna have to go through withdrawals. Like, I don't think so, right? So it can take a woman a long time to be ready to actually make some sort of change. And that's where that kindness and compassion comes in, is like just being consistently kind and compassionate will make you the people that they turn to when they're ready to make that change.
Yeah, that insight is super helpful. I think also maybe the reason I was driven to make that comment in the chat was just because I think so many people talk about pregnancy as a great opportunity for change, right? Like it's a great motivator, but at the same time, it's one of the biggest stressors and changes in women's lives too. So I think, you know, I with talking about sometimes things being a positive motivator, that can, in some ways, like you mentioned about other aspects of your care, that can actually just increase the pressure and potentially make things worse. So I was kind of reflecting on that, hearing your story.
Yeah.
So thanks.
Yeah, the first question I always ask a woman, so we have a lot of women who are in our program who end up pregnant again. The first question I always ask is, are we happy about this? That's like the first question I ask about a pregnancy, because I think in our society, you know, we hear pregnancy and we're just automatically, oh, congratulations. And, and you know, a lot of women I work with, they have sexual abuse trauma and it's not a pleasant experience for them to be pregnant or give birth. And that's the other big thing I always try to, especially when I'm like talking to hospitals and things like that, is that, you know, birth is not this like happy go lucky time, especially for the women like I work with. There's so much anxiety. A lot of the women I work with are on medication for opiate use disorder, and they're anticipating a 51A being filed. And for most of my patients, they just play this loop of their child being removed from them over and over and over again, leading up to delivery. And so, and, you know, after delivery, it's all eyes on them, and, you know, they have to be on 24/7. They just feel like everything they do is being documented and reported back to DCF. And so, you know, just being as kind as possible, I think is the best advice I can give.
I guess, you know, we're bumping up against 1 o'clock, and I mean, I feel like this group, we would want to talk for much longer. But, you know, whenever we have conversations and we're out and about talking about substance use disorder in pregnancy and in substance use disorder or opiate use disorder in general. You know, I think that what you present is this hope, the hope and the let's get there. We can get there eventually. Like, just don't give up. It's going to be and so I celebrate what you're doing. I thank you, and I'm really appreciative for you coming on today. So thanks to everybody for signing on. We'll see you in a month. I hope you all stay well, stay healthy, keep doing great work. And Letitia, thank you so much. Wendy, thank you so much. And next month, we'll be talking about control charts, which Wendy was hinting at with some of the stuff that she was showing, a more complex way to look at data. And we'll be talking more about the severe maternal morbidity data that we're learning about here in Massachusetts. So it's our own data from our own hospitals. So we'll see you all later. These slides will be up, as well as a recording. And I hope you're all well. Happy New Year. Bye-bye.